topic. So very happy to talk about it at any given opportunity. Of course, my bias is from a maternity care perspective, so that'll be fairly obvious as we go through, but we're close family members in the medical practice, so hopefully it's all relatively relatable and transferable. So some of the learning objectives, this is not written in the accurate language that we're supposed to have for learning objectives these days. It's sort of a question answer. But at the end of this conversation, what I would hope is that folks that are participating are able to describe what harm reduction means, to appreciate it as a philosophical approach to care, and to be able to imagine ways to apply it in neonatology. So the philosophy of harm reduction, the language actually on this particular slide is pulled from the National Harm Reduction Coalition. They have an excellent body of materials that you can find online that are really, easy to read, very applicable to a variety of kinds of academic backgrounds, so that anybody within an organization can sort of find these relatable and understandable. But harm reduction itself is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. And that can be fairly broad in terms of what that actually looks like. So the harms that are impacted or a result of unstable drug use, particularly in pregnancy where I live and work, we think about things like overdose death. We think about things like sexually transmitted bloodborne infections, congenital syphilis did not used to, but we eradicated that from our medical world, and its recovery is not anybody's good news. But we're also right now in a terrible resurgence of HIV increases in Manitoba. At the moment, we are having 1 new case a day. There are, of course, fetal and newborn harms that are consequent of unstable substance use during pregnancy. There is a wide range of social instability. That's the catch-all phrase for all kinds of stuff, but can include anything from worsening poverty to exploitation to psychosocial or psychiatric decompensation, and then high-grade infections, so things like sepsis and endocarditis. So that whole spectrum of kinds of experience are the harms that we sort of are thinking about. And harm reduction, in contrast, is a spectrum of approach. So it is a movement for social justice. It's built in the belief and respect for the rights of people who use drugs. A lot of the sort of materials from the Harm Reduction Network of Manitoba include these stickers that say, "I heart someone who uses drugs," really trying to personalize and humanize folks that use substances that are outside of that legal sort of catch, and how to approach care. So it's grounded in ideas of respect, acceptance, empowerment, compassion, and collaboration. And that collaboration piece is, in terms of medical care, is really seeing the patient as a collaborator, which in neonatology is a little tricky because they're not super articulate when you guys get them. But babies do their own ways of communicating, and their experience is sometimes very keenly expressed, but trying to understand their language is a huge part of trying to provide appropriate care. So one of the great tenets or principal tenets of harm reduction is this concept of unconditional positive regard. And this is actually quite a high level aspiration in terms of not only care and a care philosophy, but also just being a person on earth. As a parent, one wants to have unconditional positive regard for one's children. As a partner in a relationship, one might want to have unconditional positive regard for one's partner. This is actually not a real throwaway phrase. This is important work. So when we apply that in my line of work, that is to regard folks who use drugs in pregnancy as inherently good, capable of making decisions for themselves, and entitled to respect and dignity. And these are the markers on my road This is where I know I'm inside of my lane if I am remembering to treat people as inherently good, remembering to treat them as completely capable of choosing what's right for them, and remembering to honor, respect, and dignity in our care encounters. So unconditional positive regard appreciates that people make choices based on their unique needs, experiences, and circumstances. It acknowledges that everyone is different and what's right for one person may not be right for another. And you'll see that I've got the expression make choices in quotes here. Choice is very complicated, and we sort of have a tendency to think about it as something simplistic or preferential, and that a person makes a black and white decision or makes an elective plan and follows through with it. I had actually the concept of choice really, I think, quite beautifully articulated for me by a patient who was a sex trade worker, and she was talking about choice and how people like to sort of perseverate on this idea. And she said, choice is going to a deli counter and seeing every kind of meat that's out there, including all of your favorites, and beautifully displayed exactly as you would want to see them, and you've got enough money in your pocket to pick anything you want. That's choice. And as soon as real or perceived survival becomes one of the items in that display case, choice is no longer the right word. And for folks in their day-to-day decision-making, it is very often a sense of either their emotional survival or social survival or physical survival that is driving decision-making. And so the word choice is a little bit soft for that experience. When we think about folks who use drugs in pregnancy, we know that there's an overrepresentation of a history of trauma, depression, adverse childhood experiences, ADHD and autistic spectrum disorder, gender-based violence, poverty, intergenerational trauma, grief, and racism. And none of those things are chosen. So the idea of like good choices, bad choices is insufficiently nuanced to really kind of understand why people use drugs during pregnancy, what it's doing for and where it comes from within their life story. And to, I think about choice in a more mature kind of way. This isn't just sort of somebody went to a party and had a particularly fantastic time and decided they wanted to have fun forever. The reality is that people who use drugs for good reasons. Some folks will use drugs to avoid committing suicide that day. Some people will use drugs in order to suppress the pain that they live with physically so that they can function. Some people will use it to suppress withdrawal symptoms so that it can be normal. There's a huge range. And I think when we come to people's stories from an assumption that their decision to use drugs during their pregnancy is actually like motivated out of something that's quite legitimate, it's very easy to feel compassion for that experience, and it's very easy to then provide supportive care. So some of the principles of harm reduction include the idea that drugs are real. This is part of our shared human history. We have normalized alcohol use so much so that we actually have a dedicated enzyme, alcohol dehydrogenase, that is part of our genetic makeup, that we have cannabinoid receptors, we have opioid receptors. These are not new things. And our bodies have adapted to them, and so should our societies. In terms of thinking about them as just, these are realities. The idea that they should go away or that it shouldn't exist is unrealistic. The appreciation that drug use is complex. Sort of as suggested before, it's not just that you went to like such a rad rave that you needed to kind of keep up with that meth train that you were riding. It's actually, for the vast majority of folks, if they have an exposure to what we call hard drugs, so methamphetamines, cocaine, heroin, the vast majority of people who have an experience of those drugs never use them again. They don't develop a problem with it. It is a very small subset of people with very specific risk factors that end up having an addictive relationship with a substance, and that means that they continue to use it despite harms that it's causing their lives. A harm reduction approach to drug use in pregnancy establishes that individual and community life and well-being are the priority, not abstinence necessarily. So a lot of the programs that exist in the world of medicalized addiction treatment require sobriety first. So all of the residential treatment programs that you might go to in Manitoba require that you've been abstinent from that substance for at least 2 weeks. This is not what we require of any other medical problem, right? You don't have to have already recovered from your heart attack to get cardiac care. You don't already have to have sugars within target to get diabetic management. But this is part of the requisite sort of approach to most of the treatment programs around drug use. And so this idea that people have to somehow white knuckle it through the most difficult part of recovery, under-supported or completely unsupported, is, I mean, a little bonkers. But then also we have this really tiny kind of pool of options for folks in that 2-week period. So we have detox, which is a very strident, locked environment in a community-based program where you go for 14 days, they confiscate your clothing, they confiscate your bags, they go through all of your belongings, they confiscate your phone, and you're not allowed to have any of that autonomy or individuality because they've had the previous experience of people bringing in supply. And you're in this, like, the weirdest camp in the world where you're sort of in this environment with everybody else also avidly in withdrawal, avidly recovering from really complex use. And we've got one place like that in Winnipeg right now. And it's got 12 beds, which is not exactly adequate to the need that we have. The other alternative is to use the hospital environments, which are even smaller and are preserved for folks with much more acute needs. So this, even just the idea of achieving sobriety, quote unquote, is problematized and overvalued in terms of this is the be all and end all of care. A harm reduction approach to drug use requires non-judgmentalism. And one of the ways that this was, particularly kind of hit home for me, I work in a shared care practice at HSC Women's, and we provide care for folks that have psychosocial comorbidities. And so this is like kind of bread and butter of my workplace, right? So my patients use heroin, my patients use meth, my patients drink alcohol. It's sort of just part of the conversation. And their encounter with care that's non-judgmental has been really impressive. So we had a PhD candidate come and study our clinic, and they did interviews with folks who'd had their pregnancy overseen in this model. And on average, in a 45-minute interval, the phrase non-judgmental is brought up on typically 18 times. And that tells me how much people were expecting to be judged. And it says a lot more about, I think, actually medicine as a whole and not as much about us. I don't think we're doing anything all that fancy. I think that the experience of judgmentalism is just that potent. A harm reduction approach ensures that people who use drugs and have a history of drug use have a real voice in the creation of programs and policies designed to serve them. So most recently, our government presented Bill 33, which was to require individualized licensure for anybody with any role in addictions care anywhere in Manitoba outside of institutions like hospitals and prisons. And at no point did they consult the community of care providers. So no one in the addictions medicine world knew anything about this bill coming up, and certainly nobody with lived experience was consulted. So that idea of nothing about me without me being fundamental to an approach to harm reduction, that there is no real role for policies that are not designed in communication and collaboration with the folks that they affect. Harm reduction also affirms folks that who use drugs as the primary agents of reducing their harms. So this is the principle of doing with, not for. So this sort of shifts away from that paternalistic approach to care of we know best and we're going to take care of these things, and really sort of seeing agency in the individual and doing our part is removing barriers to them seeking their own goals and enacting their own values. Harm reduction also recognizes the realities of marginalization as a primary driver in drug-related harms. And that's partly as like a risk factor sort of picture, but then also partly in the experience of the harms. So for example, Indigenous folks have a higher burden of infectious outcomes with drug use. So their risk for sepsis is 3 times higher than the white person in the exact same situation. And so we see a measure of how marginalization impacts the outcome as well as informing the risk factors. And poverty manifests itself in small gestational weight, right? So not only does it sort of set things up negatively to have an encounter with marginalization, it also worsens the outcomes downstream as well. Folks that go to prison for their drug use are overwhelmingly people that are Black, Indigenous, or persons of color. And lastly, harm reduction does not attempt to minimize or ignore the real and tragic harms of drug use. So there is a devastating consequence, and I see it in my patients losing custody of their children, losing their lives completely. You guys see it in the suffering that children live with and endure, and the complications where, you know, I think it's sometimes hard to impress upon patients that a small baby is not just easier to deliver vaginally, that's actually not kind of a good thing. That the consequences of that for this little kiddo trying to achieve their first breath of life or trying to gain weight, we all sort of see that this is very real, the costs are high, and it's not immaterial. These aren't just sort of theoretical things to sort of, you know, posit about. So a lot of what that all talks about is stigma, and where stigma plays a role in how we think about drug use and how drug use manifests. I was asked actually once to do a talk about stimulant use in pregnancy. And I started with the conversation with the most deleterious stimulant in pregnant populations, the one that causes the most harm and is the most dangerous, and that's nicotine. And it's not methamphetamines, and it's not cocaine. Actually, they kind of pale in comparison. But because smoking is so normalized, and because it's legal, and because you don't have to get it out of a dark alley, we have this, our morals start to, like, you know, push things aside, and we can often sort of dismiss the idea, like, well, I mean, she smokes, but did you hear about the meth? And frankly, the smoking, in most cases, it's much more harmful. So in terms of that stigma, it comes into our interactions with folks, but also within their communities. So people who use drugs often encounter more stigma when they're pregnant. Very often, and I see this in my practice, where I will have a partner saying, she's got to quit. You got to make her quit, while he's not only actively using but selling. But she's being a bad mom by continuing to use. And there's this bad mom sort of like label is really powerful in terms of not only how it affects a person's self-esteem, but it also really impacts their access to care. So that comes into this concept of blame. And this is really well described by Mary Hepburn in her book, Drug Use and Parenting. Drug use in pregnancy, in terms of social perception, I think also very well reflected in mainstream medicine, is considered a form of child abuse. And we've had some, like, you know, important cases go as far as the Supreme Court around right to decision make in terms of substance use during pregnancy. There's sort of 3 main themes. Like, one is a lack of maternal commitment. You know, if you could just put your child first for a minute, you would stop doing what you're doing. Like, think of your baby. Like, why can't you think of your baby? That patients don't just get that implicit message, they get that very explicitly stated to them many times over. And this idea that, you know, somebody's just not a committed mother, frankly, if you have the opportunity to meet somebody who's pregnant and uses drugs, and she tells you, the only reason she tells you is because she's considering the baby, right? She's not interested in your judgment, right? She's not, that's not what she's here for. She's here only because of her deep and abiding concern for her infant. There's also this idea of the bad choice brigade. So folks who use drugs are folks that just generally make bad decisions. They're kind of immature. They're very like, can't delay gratification and yada, yada, yada. And this sort of allows us to dismiss them as important decision makers, as collaborators in their care, but also as people who should contribute to policy. And then this idea of them being deceitful. I remember when I was in medical school, our first lecture about addiction, the prof stood up at the front of the lecture theater and he said, addicts do 3 things. They lie, and they lie. And that perception is incredibly pervasive. And one of the questions I get from learners the most often is, how can you tell when your patients are lying to you? And I tell them I can't. I'm not a human lie detector. That's not my expertise. My job is to make my care environment so safe, there's no need for them to. And if I can make it effortless for folks to tell the truth, then I can provide care that actually is tailored to their needs and their goals of care. And my patients tell me all their business. I don't struggle at all with deception in my practice. When my patients are on methadone and they're using on top, they very often will tell me, because that's a way we measure the success of their therapy. And when I frame it that way, they're like, oh, well, in that case, I've been like shooting dillies like 6 times a day in the last week. Okay, so maybe your methadone's too low. Like, let's figure this out together. And when I give people that opportunity to share their story from their perspective, understanding what I'm going to do with that information, it's quite different. So one of the really important sort of features or the messages around sort of drug use in pregnancy is that it's a social phenomenon, not an individual problem. And the analogy that I often use with this is, you can look at each individual red blemish and think of it isolated and miss a diagnosis of chickenpox, right? This is systemic. So we see unstable drug use wildly overrepresented in populations that suffer marginalization. We see it wildly overrepresented in populations that suffer poverty. And we see an incredible disproportionate history of trauma and adverse childhood experiences. So when it's the same sorts of folk that have an outcome, you're running into social injustice. That's how you can tell. Very often the negative obstetrical outcomes attributed to drug use in pregnancy are mostly kind of ascribed to late presentations to care and medical non-adherence and lack of honest disclosure. These are sort of the kind of pervasive assumptions that belie these negative outcomes. However, there's a really good comprehensive study that was done mostly out of Scotland, but with multi-center involvement across the Commonwealth. Folks who sought prenatal care in environments that were non-judgmental actually presented earlier for care, presented more often, and were completely counted with their use. And despite that, their obstetrical outcomes did not improve, because that's not really the problem. The real problem is marginalization and poverty and experiences of trauma and adverse childhood experiences. So that what we saw is things like premature birth and low weight for gestational age. We saw that absolutely in step with non-drug using populations of similar socioeconomic strata. So the old adage is think of the children, and I do really encourage people to think of the mother. So in substance-involved pregnancy, the literature has a 35-to-1 predisposition to focus on fetal versus maternal outcomes. And for the vast majority, the maternal outcomes are really just about preeclampsia. So there's this little sliver of literature that's starting to emerge. It's like, oh, hey, these are people with stories, and they all have some similar themes. So intimate partner violence, experience of suicidality, overdose, depression, which are under-recognized, under-treated, and really overshadowed by the fact that they use the bad drugs. So stopping the stigma that surrounds substance-involved pregnancy is actually one of the harms to reduce. So when we look at this whole sort of wheel of harms, there are some that are particular to pregnancy. So the physiology of pregnancy increases metabolism of opioids. So very often what was a stable dose of Suboxone or methadone is no longer stable in pregnancy because they just burn through it faster. What that also means is they burn through it faster. They can overdose more easily. So what was a safe dose pre-pregnancy can become a lethal one during pregnancy. The cardiac harms of amphetamines are amplified in pregnancy. We really don't understand why. So it's not just the catecholamine burden that we see with like other stimulants, like cocaine just like jacks up your blood pressure and your heart rate, and it's just a lot of strain. But there is actually sort of a myocyte specific toxicity of methamphetamines. And so we see cardiomyopathy develop more prominently in pregnancy than in any other population, and associated with pulmonary hypertension in that pregnant population as well. So a pregnancy that's associated with pulmonary hypertension has a 50-50 mortality rate. So this is like, these are high stakes. Pregnancy also amplifies the liver and brain toxicities of alcohol, and that's even more so if they've got gestational diabetes for reasons that we don't understand. Seroconversion to HIV positive status is increased by 4 times during pregnancy. There are some immunomodulations in the pregnant sort of interval that we assume play a role, but we don't really have that well articulated yet. And also pregnancy predisposes patients to risk for sepsis by about 3-fold. And that might have to do with some of the lack of vascular resistance that predisposes folks to interstitial sort of edema and things like that, that are hallmarks of sepsis. Psychology of pregnancy, they're at the highest risk for intimate partner violence in their life. So at no other time in a woman's life course is she more likely to be beaten by her partner than while she's pregnant. And it's most often in the 3rd trimester, which is the most counterintuitive sentence that I tend to say. Pregnancy is an independent risk factor for unemployment. Substance use in pregnancy increases postpartum depression by 2 to 4-fold, and that range of 2 times to 4 times is racialized. Up to 11 times of an increase in terms of suicidal ideation during pregnancy than outside, and infant apprehension increases the overdose risk by 2 to 4-fold. And again, that's also a racialized range. In terms of the fetal harms and those negative obstetrical outcomes that the newborn sort of bears the brunt, methamphetamines increase preterm birth by 17 times. So a little bit hard to tease out all the confounders from that, exactly how much of it can we ascribe just to meth and how much do we give credit to things like poverty and marginalization, all those other sorts of important risk factors. Unstable opioid use increases prematurity and stillbirth by 16 times. Alcohol produces a placental insufficiency that's worse in terms of neurological outcomes than just IUGR alone. And concurrent smoking basically doubles all the badness of all the other drugs. So from a harm reduction perspective, actually, if somebody's not ready to make a change with their meth use and not ready to make a change with their alcohol use, if you can get them to quit smoking, you've done a tremendous good. So really sort of thinking about like, where are the little harms? Where are the big harms? What can you actually intervene with? And overall, the math adds up quite well. So it feels like a lot, right? The harms feel overwhelming, the amount of bad that's out there. But that also means that the potential for benefit is dramatic. So you don't have to solve all of these problems. I don't have to like cure overdose death and social instability and sepsis and congenital syphilis this week, but I can at least focus on what makes the most sense to me, my talents and interests, and make impact on that. And so each individual in our care sort of world can do that, and we can all sort of collectively reduce those harms. So in terms of harm reduction in the antepartum interval, some of them are really simple. So optimizing maternal hemoglobin reduces postpartum depression. Careful glycemic control reduces sepsis. Treating and preventing opioid withdrawal reduces overdose. And stable housing improves the likelihood that a mom and a baby are going to be discharged together. And that's independent of anything else. If she's got stable housing and still using meth, she's more likely to get discharged with her kiddo. If she's got stable housing and in a, otherwise, other kinds of social instability, like she's unemployed, she maybe has been removed from her home community, she's got some other challenges, just having a place to safely live improves all those other outcomes. But these exact same things also help the baby. So optimizing maternal hemoglobin reduces the severity and incidence of fetal alcohol syndrome. Glycemic control also reduces FASD. Treating and preventing opioid withdrawal reduces preterm birth and small for gestational age, and stable housing improves birth weight and term birth. Examples of harm reduction in the intrapartum interval, HIV prophylaxis. One of the approaches that I have is I will talk with patients and I'll say, you know, we have these medicines that are available for anybody who is worried that they might be at risk for HIV exposure. So if since your last HIV test, you have had unprotected sex, you shared a needle or a pipe with somebody, I would be happy to provide this medicine for you to protect your baby from HIV we don't know about yet. And you don't have to explain to me why you think you might benefit from this medicine, you just let me know you do. And patients very often say, yep, sign me up for that. And they don't have to tell me, you know, I did this thing with that person in this other business, that's not my concern. And then it also minimizes that barrier of shame that might have prevented them from asking for the prophylaxis. Other things can be like trauma-informed practices. So using the fetal heart monitors that wrap around the patient's belly and have bands actually can be very provocative for folks that have a trauma history. They feel bound and tied up. And so just taking the bands off and allowing them to hold the monitor on themselves, we get a much better tracing from the baby because we don't have a patient who's fighting the monitors, and we don't re-traumatize the patient unintentionally. Prompt and effective opioid withdrawal management also optimizes perfusion to the placenta and gives you guys a little less to do when the baby's born. In the postpartum interval, skin-to-skin feeding, and that doesn't have to be breastfeeding, that can be bottle feeding, decreases postpartum depression. Breastfeeding decreases postpartum hemorrhage. Eat, sleep, console protocols increase parental custody, and access to postpartum follow-up decreases suicide. Those are all pretty major outcomes, but the exact same thing for baby. Skin-to-skin feeding decreases NAS scores and the likelihood that they might need morphine. Breastfeed decreases infant upper respiratory tract infections. Eat, sleep, console increases newborn weight gain, and access to postpartum follow-up increases newborn vaccination rates. So in general, kind of what is good for mom is also good for the baby. Now I've got some stuff that's more specific to Eat, Sleep, Console, but I thought I would maybe pause here just to sort of like catch up with questions and discussion. I'll give you guys these slides, and if we don't get to this content, it's pretty self-explanatory. But I just thought I would maybe take a break and invite some questions and discussions at this point. Question from online? No.
Well, I will point out your point about stable housing is fantastic. I mean, I don't know how often, and I see we have Alicia, the social worker from St. Boniface on as well, that we have, you know, women that come in that have their children apprehended, and it's because they have nowhere to stay, or the place they have to stay they have a violent partner. Mm-hmm. And so it's things that are outside their control. And those are the ones, I mean, it just makes my heart break for them because, you know, they're doing everything they can, but there's this barrier that they cannot address. And so their children get apprehended really, again, through no fault of their own, because they have nowhere to go that's safe.
Yeah. And that characteristic of something that you can't control, that's the fundamental characteristic of trauma, right? That incredible vulnerability, this scary, big, bad thing that I can't stop happening to me, and no one else is stopping it either. That's sort of the defining characteristics of a trauma experience. So apprehension is also a trauma experience, and those have like a really multiplicative effect in terms of substance use. I see it a lot. That I had a patient whose infant was apprehended because she did not yet change her locks. She had broken up with the bad boyfriend that CFS didn't approve of, but she hadn't changed the locks in her apartment. And so her infant was removed from her care. And so there's impacts in terms of trust in the system. That was a long. I don't think it's really common in characteristics, but Impressive.
Just to add to that, Chelsea, hi, Dr. Watson. I'm Alicia, the social work from NICU at St. B. Just to add to that, even the disparity of resources between child and family services agencies. Some agencies seem to have greater access to bigger pots for support as opposed to others who are a little bit more limited for whatever reason. And so what I can offer, what we can work with for some families is not even a possibility for others. So it's so hard to try to help people when they want the help.
And then also then it can be a little traumatizing for the care provider, right? You're out there doing like your absolute best to advocate for a family, and you can feel really up against it when you know if you were dealing with this community, you had these resources, and just by the sheer geography of this person's birthplace, they don't have access.
Exactly.
I have a question. Like, I was just wondering, like, how often do you see, like, especially moms that declined or did not disclose the use of substance in pregnancy due to maybe fear of apprehension or some other things like that? Like, how rampant is it?
I would say 100% of the patients that I see are afraid their baby's going to get taken away if they tell me the truth of what's going on. But they also are afraid their baby's going to be hurt by what they're doing. And so their fear for the baby's well-being very often can trump their fear of apprehension. So part of my job when I have a first encounter with patients, we do our like usual kind of history taking, any twins in the family, any malformations at birth, blah, 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 get to that risk stratification. But then I also tell people what my biases are. And I tell them, I'm a big believer that moms and babies belong together, and that I will do whatever I can. If that's your value, if you want to parent this baby, I'll do whatever I can to help you reach that goal. And that's, when I sort of lay that groundwork, very often people say, so I'm actually using a lot of down, and now we can talk about it. And so what I find is that folks that have that fear and they don't want to disclose at their very first visit, really, really common. If that's still true by the second visit, very rare, and almost never by the time of delivery. That once they have that safety buffer, that actually disclosure is going to improve the likelihood that they get discharged together with their baby, they're all for it.
And Heather, do you liaise directly with Child and Family Services? Because this is I know there's a whole bunch of different Child and Family Services organizations, but some years ago when I was doing the insight evaluation, I presented to Child and Family Services about neonatal withdrawal and like the complete lack of understanding by Child and Family Services workers on just substance use in pregnancy. Now this was, over 10 years ago, but like just basic things, like they didn't understand that babies withdrew both from prescription substances and from, non-prescription substances. And there was just this overwhelming idea that anybody who used substances in pregnancy was therefore unfit to parent, and that all babies born to folks who use substances in pregnancy are premature and have multiple anomalies. I'm like, no, most babies are fine.
Yeah, and it's actually the legal drugs that are going to be more deleterious. Alcohol is going to do a lot more harm than opioids will. But our moral sort of like twigginess is going to sort of get in the way. I do not liaise with Child and Family Services in any regularity. And that's partly because I keep a very separated role. And that's partly because it's very real. I don't have any authority with which to tell them they should or shouldn't apprehend. I wish I did. I wish I could be more influential. I will write I tell patients that I'm good at bossy letters, and I will write letters on their behalf. Anytime that there's a lot of automatic referral to social work in our postpartum population, which is in and of itself, the list of indications for automatic referral is, I find, very uncomfortable. They don't require consent for these referrals, and there should be a very short list of anything in medicine that does not require consent. But what I will often do is I'll see a referral in there and I will put an append, I'll append that referral and I'll say, this patient has been completely care engaged, has been highly motivated for the benefit of their child. They've attended every ultrasound, every prenatal visit. They have been working very hard with these things and those things and those things. And I'm absolutely comfortable that they are committed and caring parents. And I have with your kids.
Can I just chime in again a little bit? Sorry. Further to that point, yeah, you're right. The consults that get entered are completely judgmental, unnecessary. And the nurses don't understand what a social worker showing up on your doorstep saying hi means to people. You know, they think we're here to support, but automatically I am seen as someone who works for CFS. So oftentimes we will get those referrals and do a chart review and just discontinue. Please call us if there is an actual child protection concern, but there's nothing noted here otherwise, based on this, and this, as is indicated in her prenatals.
I really appreciate that part of your approach, and we don't see that on the postpartum unit. That's not sort of the mandate that's there at the present. And so actually putting together the Eat, Sleep, Console guidelines, we ran into this because it was sort of going to be an automatic referral if you were doing ESC that you had to see social work. And we got talking about it and it was like, you know, someone who's been on methadone at a stable dose for 10 years still might need Eat, Sleep, Console oversight, but they don't need a social worker.
Exactly that. It's also not to say I'm here to work and I'm happy to work, but it's a waste of my time. Like I would never see somebody just because they're on antidepressants. Like why? It's so presumptuous, and I'm triggered right now, so I'm gonna go off the camera.
But that's so real. Like I say that all the time. Our social workers are busy enough. Like no one has ever said, I think the social workers have too light of a caseload. Let's give them some like make work. That shouldn't exist. And so the triggering of a social worker coming, for lots of people, that's how they were taken from their parents. So we're not just worrying them about their current moment, we're like digging deep into like very old, very painful stuff. And in kind of this, we're doing it to help way, but it's not helpful help. And it's that sort of moralized, condescending help of we know better. And as we evolve in our growth as a discipline in medicine, I think we are moving away from that model slowly but surely. And I think that eventually that will become extinct, but we have to forcibly make it get extinct in the meantime, because it is a harm. One of the harms that can be reduced is the triggering, overwhelming experience of a social worker showing up unbidden at your door when you gave birth 4 hours ago. So I will, maybe I'll take that to carry on to the Eat, Sleep, Console content, just because it's sort of relevant to what we're talking about. So neonatal abstinence, there was a really interesting study that was done between London, England and London, Ontario. I don't know who met whom at what conference, but like, you just know, like somebody had a conversation saying, we're going to do the London trials. They followed 18,000 parent-infant dyads of births that were impacted by neonatal abstinence or neonatal opioid withdrawal syndrome. So there's NAS and there's NOWs, and like that gets a bit muddied in the literature. But they were using neonatal abstinence as a surrogate for opioid use severity. So the assumption being that folks that had unstable opioid use are going to have higher scoring infants. And that was something you could measure, whereas you couldn't reliably measure how much opioids do people use. And they were actually quite surprised by the outcomes. So 1 in 20 mothers who had delivered a baby who scored on NAS scoring died within 10 years of the birth of that baby. And when you think about reproductive age, this is a tragic loss of years lived. It was about 12 times the mortality of age-matched peers. It was disproportionate to the mortality that's only related to drug use. Maternal age was not a risk factor, so if you were 40 or you were 20, that didn't seem to impact. And that the vast majority of deaths, I think it was more than 85%, were deemed preventable. The folks who did fall into that 1 in 20 category were generally younger. They generally occupied the lowest income quartile. They had a disproportionate history of psychiatric hospitalization. So folks who survived after having had an infant score positively for NAS, they had less than 1% frequency of having been psychiatrically hospitalized compared to 13%. That's a dramatic interval. And a much higher rate of infant discharge into foster care. So 9% versus less than 1%. So when in this paper, they sort of talked about what's the natural history that leads to the mortality that they're describing. So it begins early, right? So the psychosocial risk factors for unstable drug use, mental illness, trauma, marginalization. Then you have your unstable drug use, particularly opioid use in this case, but it can be confounded by things like gabapentin and benzodiazepine use. Independent risk factors for unstable drug use include intimate partner violence, homelessness, depression, even just any medical comorbidity. So hepatitis C, for example, increased the likelihood of unstable drug use, particularly of opioids. Then you have the experience, the maternal experience of neonatal abstinence. And this is a really overwhelming experience for parents. They are incredibly distressed. They have very dense experiences of guilt and shame. Very often at the next pregnancy, but the first visit that they see with me, I'll say, what is something that you would like to be different in this pregnancy experience than previous? And they say, I don't want my kid to have withdrawals. It ruined me. I want a baby that doesn't withdraw. And that's been in their mind ever since that baby was born. And then infant apprehension itself. So the loss of maternal role, as soon as the baby's apprehended, also every other support goes away. So whatever social programming that they had plugged into during pregnancy, it's gone as soon as the baby is. So that becomes psychosocial risk factors for unstable use. So you get this real spiraling around their use experience. So there's a really great article. Actually, I find a lot of the most rich literature on this topic comes out of the nursing literature, rather than medicine, physician-driven literature, and you can derive from that what you will. Mothers of infants with neonatal abstinence express guilt, shame, in a sense they have been judged by staff, all disrupting the formation of trusting alliances with hospital providers. And that translates to the rest of a person's life trajectory. So any bad experience a person has at the hospital makes them less likely to ever go to the hospital, whether it's for another pregnancy or a heart attack. One of the patients in this study said, I felt a little bit of it, like judginess, but I couldn't understand why, because I didn't know he was being looked at as a baby who was going through withdrawals. I had no idea. I was just like, what have I done to these women? And she means the nurses. Why don't they like me? But then I realized they just thought of me like any other junkie. The maternal experience of infant withdrawal is really intense. My patients are often in an experience of trauma in that moment. They're overwhelmed. They assume that infant withdrawal is the same as adult opioid withdrawal. Adult opioid withdrawal is excruciatingly painful, head to foot. They are throwing up, they've got diarrhea, their eyes are running, their nose is running. They feel hot, cold, they have incredible panic. They feel like they're dying, and they assume that their baby feels like it's dying, and they are beside themselves. They feel like they're indirectly torturing their child. They feel helpless to protect them, and they have to force themselves to stay. And this is what I didn't come to understand this until more recently, that for a mom to stay in the room and bear witness to her child's suffering in that moment is every ounce of her energy. Right, because she feels so responsible and so guilty, but she needs to be there, and so she forces herself to stay. One of the patients in that same study said that if a woman doesn't know what to expect and she has a baby and they start to go through withdrawal, she doesn't know why her baby's crying all the time. Why can't I console them? What's going on? They think of themselves as a bad mom. It takes an emotional and mental toll on them, and on the dad, because they just don't know how to help this little kiddo. In the experience of Eat, Sleep, Console protocols, in contrast, moms and dads feel supported and informed. They understand that infant withdrawal is not the same as adult withdrawal. So the thing that I often will say to patients is, we know that babies who have routine care have as much as a 60% chance of needing morphine. Babies that get lots of swaddling, skin to skin, breastfeeding have like an 11% chance that they might need morphine. Have you ever had withdrawal that someone could cuddle away? No, no one can cuddle away your adult opioid withdrawal. I can cuddle away the infant experience. So understanding that intensity of experience is really important to help them kind of like take those stakes down a little bit and be a little less panicked. And then they can also feel like they're the medicine, right? My cuddles, we know that babies do best if they're in the same room as their biological parents, especially if it's in the arms of those bio parents. So I tell patients all the time, you're your baby's medicine. Your breast milk, because it's got some traces in it, but also just your cuddles are better cuddles than other people's cuddles. And so reaffirming that role and the specialness of that role is really empowering. They also then feel like they can protect their baby, they can prevent their suffering, and then they're motivated to engage. They're not having to force themselves to stay in this awful moment. They're like, I'm here for you, kiddo. And they feel like they can champion for their baby. So kind of summing all that up, just in terms of a harm reduction sort of approach, from where I sit, these concepts of collaboration and respect, acceptance, empowerment, and compassion just become the language with which you speak to patients. And you guys, you know, where we have a similarity in our disciplines, because I've got my patient with a secret other patient, and you guys have your patient with a very vocal other patient, right? You got to deal with that parent vibe. And babies get up to their mischief, but they often keep their opinions to themselves. But that sort of dynamic of trying to mitigate that parent role when you're being provider to the infant can be a real challenge. And I appreciate the hard work that you guys do. In those cases, when in doubt, increase agency and decrease shame. And you almost always get a different quality of engagement from that parent. And what's good for moms is good for babies all the time. So we've just got a few minutes left. I really appreciate everybody's time. Any other questions, thoughts, feelings, indigestion?
Hi, Heather. Thank you for joining us and for such elaborative and helpful talk. I'm Mansoor from neonatology. Is there any channel or communication between us and to the CSF about building that education gap of the CSF, like how to protect that and how we can be more helpful to the such type of mother?
It's tough. There isn't an obvious pathway, and I think that's part of the work that needs to be done. I work with a broad group of an interprofessional group that is really motivated around advocacy and actually like really trying to change the dialogue around CFS role in substance exposed pregnancies. I think is a really important first step. And so outside of the kind of structures of the hospital, we're trying to do some work, but I think there does need to be some reciprocity with all the stakeholders, right? So maternity care providers, newborn care providers, child family services, and families who have been impacted by either having grown up in the foster care system or losing an infant to the foster care system. I think that conversation could be so rich and important and could transform what's been going on in Manitoba. I think we really see in terms of the very first call to action in Truth and Reconciliation is around the apprehension of infants out of their families and out of their communities. And this is a historic, massive injustice. So it's super, super triggering in our Indigenous populations. But that gives us opportunity for healing and growth and recovery. And I think that needs to be built. And it wouldn't be hard. It's just a matter of the most welcoming invitation to all of those parties so that everybody feels like they're accepted and welcome. CFS workers often feel like they're the bad guys, and they come into the room and everybody kind of quietly hates them. But they also feel really committed to doing work and protecting kids. So having that respectful dialogue, I think, needs to happen. It doesn't exist yet, but that doesn't mean we can't make it exist.
Thank you.
I have another question. Like, at what gestational age is the maternal autonomy is taken away from the, like, I think before the age of viability, mom's autonomy supersedes that of
Pregnancy.
Oh, yeah,
all
never,
pregnancy now?
Yeah.
Okay.
always.
It's a month.
Yeah, so there was actually a landmark case that came out of Manitoba, a mother who used solvents. And Child and Family Services went to the Queen's Bench and actually got empowered to forcibly remove her from her community and put her into involuntary treatment for her addiction. And this case went all the way to the Supreme Court, and the Supreme Court overturned it, right? And said, this is an intelligent human being that can make care decisions for themselves, and we cannot make that kind of an imposition. So the case was, successful. It all happened relatively quickly. She was pregnant, so they kind of had to. And it was completed at about 7 months gestation. And she was discharged from the program. And she went from that program and directly asked for admission into another program, because she actually did want to recover. But she understood that if her story went all the way through to delivery with her involuntary participation in a program, she would ruin choice for women across the country.
Yeah.
So she had enough political sort of like savvy to appreciate that this had a big impact outside of her own story, but then also she did want to recover from her solvent use. And so when she delivered baby, she happened to have 3 months of sobriety behind her. But that piece of the need to remove decision-making from moms doesn't ever need to be manifest. Actually, if you just provide enough support and take down enough barriers to harm reduction, and this sort of, we have an infatuation with sobriety, that doesn't have to be what's required. I have a very deep and abiding addiction to caffeine. I have no plans to achieve sobriety from my caffeine, but I do need to use it responsibly, or I get shaky in the OR. Like, there's a lot of ways that we can sort of think about harm reduction, right? And remembering that people are going to make good choices about themselves when they have good choices available.
And the second question is, does social support, like family, extended family, does it have like huge impact in reducing the occurrence of maybe apprehension, regardless of mother states,
Yep.
or birth alert, like as soon as they deliver the
Yep,
birth alert?
absolutely. So it makes a huge difference if they've got family involved. CFS is much less likely to assert themselves in that situation. But also, like, the small tragedy with that is that the people who need that support the most are least likely to have it. So folks that have the most unstable use are very often the most lonely, and very often their families are, using themselves. So yeah, I have one patient who, she was staying with her mom, and I was like, phew, you're staying with your mom, but her mom's using Dilaudid every 2 hours. And so for her to rein in her own illicit use, really hard to do in that setting. So it's not super cut and dry, but absolutely it makes a tremendous difference. I mean, anybody who loves on you is going to make you better.
Thank you.
Okay, well, thanks everybody so much for your time. Out of respect for it, I'll wrap things up, but if there are any last questions, I'll just stay on the Zoom here for the next little bit in case there was any burning issues that they wanted to chat about.
I think that was great. And I know that Chris has recorded it, but you're okay if we put it up. We have an internal list for folks who couldn't make it today.
Sure. Sounds great.
I think as part of our Eat, Sleep, Console rollout, it would be very helpful for
Chelsea, could I get that for the other social workers in Women and Child program, like the presentation.
Once Chris puts it up, it'll be on the link. You have the link?
Yeah.
Okay.
Okay, perfect.
Excellent. Thanks so much.
Thanks, everybody. Have a great rest of your day.
Thank you.